I want to start out by repeating I am Lora Davis, and I work for US CDC. I work with mostly with data, and I work with what they call the Strategic Information Team. So this is my thing. Data are my thing. And what I'm going to present to you is an overview of the IMRO workshops that were held last year. I think there were 2 to 3. Jan also, if you know Jan, he was also in these workshops as well. Can everyone hear me okay? All right, good. So this is going to be a little bit informal. What I want to do is update you on what was presented there and put a lens of equity on it. So the outline is going to be, we're going to review, first we need to review data quality, and we need to review data in and of themselves to get everybody on the same page. We'll look at the data quality assessments. We'll talk a little bit about population-based coverage surveys, and then I want to have a little bit of a discussion about equity and whether or not the tools that we're using, the assessments that we're conducting, actually include these populations that we call special populations. And then last, we're going to do a group work where we're going to, and I hope not everybody is completely comfortable with where they're sitting, because we're going to pull some people out and actually put them at another table. And then you'll have about 40 minutes, I hope, 40 minutes to go through some data, look at the data, discuss them, answer some questions, and then we'll do some bigger discussion as a group. So what is good data quality? There are a lot of definitions for good data quality and data quality. And if you pull people together, you know, it doesn't matter where they work, you're going to get a different definition. But I'm going to use this definition because it covers 2 key points. One, they're considered to be good quality if they contribute to a complete, unambiguous, meaningful, and correct inference. So you need something that's going to be accurate, correct, to the best of its ability. No data are perfect, but you want something correct enough so that you can manage your program better and make decisions. That's the point of the data, right? Is to make decisions based on data. So the thing that we look at the most is coverage, and that's what we're always talking about. When you're a data person, and maybe even when you're not, you look at things in terms of numerator and denominator. And that's actually, it's kind of sad, but I look at all the populations of the children. If you're in the numerator, then you also need to be in the denominator. You can't pull people from outside the denominator and put them in the numerator, right? So the numerator is the number of doses or the children administered to the target population within a specific time period. And then in the denominator, you're talking about the target population over the same period of time. And with equity, that's where we get into trouble, right? Because there are some populations, for example, in the urban areas, like what was the country? Egypt has a large urban population that may have some challenges. You have homeless populations. I don't know if Egypt experiences that. But in the urban areas, you have people that aren't counted in the denominator, but they live there full time. And so they should be counted in the denominator, so they're kind of missed. And these are certain underserved populations. You also have, in some countries where I've worked, hard-to-reach populations. These are populations that live, 2 to 3, 4 hours away from the nearest settlement, and they have a settlement way out. So they don't access health care, and they get missed from the denominator. All right, so you're not counting them. And then you have people that come into the numerator that shouldn't be in the numerator because of the fact that, say, they're visiting, or we have a lot of countries here that have refugee populations. They come into They kind of get incorporated into cities, and maybe they haven't been counted as part of the denominator. Maybe they're mobile populations and they move, right? So these are the challenges that we face, and that's why you look at coverage And you make an assumption that everybody in the numerator is automatically going to be in the denominator, right? So these are the things that we need to talk about, and this is kind of where the limitations are when it comes to data quality and looking at coverage. So when you have problems with your coverage, you have to think, in terms of data, it's either a problem with the numerator or it's a problem with the denominator. It can't be anything else. So in the numerator, we're talking about, again, and we just covered this, persons or children vaccinated from the target population, all right? You don't include those outside the catchment area. You vaccinate. We hope everyone's vaccinating the children that come in that are visitors, right? So, and then also, too, we're going to talk about catch-up vaccine. If they're not from the age group, the right age group, if you have a child come in that's 18 months of age and has not received measles 1, you still give them measles 1, right? They don't get measles 2 if they haven't had measles 1. So these are kind of some of the issues with the numerator. Let's go to denominator. And this is going to be covered in the next session in greater depth about denominator populations. It needs to be of a specific age group, defined geographical area over a specific period of time. And that, again, excludes a lot of people. It excludes people who are especially the mobile populations. It excludes refugees. It excludes IDPs. So most of what we discussed at this IMRA workshop was about doing data quality assessments. And there's some newer methodologies for data quality assessment, or it's kind of a discussion whether it's a methodology or a component, all right? So I'm going to cover a little bit of those because they're kind of aimed at looking more at the system and perhaps capturing more of these groups of people that may have been left out. So the things you can do regularly for data quality assessments: completeness and timeliness. I think people are very aware of these two components. And this is what you do routinely. This is what you should be doing in your countries regularly, is looking at completeness and timeliness of reports, looking at internal consistency, like the coverage rates over time, looking at each month from each district, from each province or state level, and then you can look at national level over time. You can also look at different sources of information, like for example, the vaccine preventable disease surveillance. You can compare that. If you're having, for example, measles outbreaks, and you have coverage of like 100%, then you know that it's not 100% coverage, right? I worked in a country for quite a long time that had measles MCV1 coverage of 110 to 120%, and yet they would have measles outbreaks routinely. And at one point in an RI meeting, we said, hey, you know what? I know that the coverage rate is still 110 to 120%, but we're doing so much better because we've only had 85 measles outbreaks instead of 120. So that's another thing you need to look at. You know that your coverage probably isn't so good. You're missing people. Your denominator may not include the right people if you're still having outbreaks. So a couple of things that can be used to help with this routine data review are having monthly meetings, quarterly meetings, where you actually discuss the data. You look at the data and discuss that with not just the people within the national level, but you can do district level discussions as well in meetings. And then also supervisory visits. Incorporating a review of data into supervisory visits is also a good idea, and what I've seen some countries do. And then there's the periodic data quality assessments. And I think pretty much everybody, has everybody done a DQS, data quality self-assessment? Pretty much, that's done like every year or every couple of years, ideally. Let me go back. I want to ask, who attended, has anybody here attended the EMRA workshop? Just kind of, nope, nobody attended? Okay. Well then, I'm not repeating myself then, okay. So the last one is a data quality assessment, which is a more in-depth assessment. We also call it the data quality review. And I think there's a lot of discussion on what the actual acronym is going to be, but we haven't come up with anything yet. Not that I'm aware of. Jan might be able to forecast something there, but he's shaking his head no. So there are some new components of the methodology that were introduced in the past couple of years, and that was one of the main reasons of having these workshops, was to introduce that to everyone within the region. So on the newer components, I'll just cover this quickly. We have the process flow is to do more of a systems assessment, where you gather and examine resources and documents. It's like part of a desk review. And this is the immunization information system, how the data are collected and how they flow up to the national level and then into the JRF and to WHO. So to do the systems assessment, you gather information as part of kind of a desk review process. And then you can do focus group interviews. The key thing is to review tools and system design, looking also at the electronic components, because that's where, in a system, an information system, that's where you can come into problems, is whenever it transfers over to the electronic portions of the system. So then there's a data desk review, which is where you compile the data from multiple sources and then look for inconsistencies. Look at trends over time, you look for inconsistencies in your data, and you do what's called data triangulation, where you look at different sources to compare the data and see, you know, if you have measles outbreaks and you have your coverage at 110, 120%, you know, where are the problems and how can you fix them? Then there's the field review, where you go out to the field and you can do data verification. That's been something that's very standard for data quality assessment. And then the last piece, which is one of the key pieces, is the improvement planning. And that's a process where you go through and you look at what the primary challenges are, you prioritize them, and start putting them into what they call improvement planning document. So these are the things that, and the newer components, starting out here in this first part, looking at the systems assessment, the overall system, and then the last part especially is the improvement planning piece. Okay. So data quality review. Are these new components, are they going to capture your special populations? When you do the review, are you going to be able to detect, you know, if you have problems with the numerator, is it because of the special populations, right? So I think the one thing, and this is my opinion, because I've gone out on a couple of these where we go to different countries and we do the data quality assessment in this manner. And the fact that we're actually sitting down and looking at the tools and making recommendations on the tools themselves, that's something that I found very useful, because in a couple of countries we did have problems with more people moving for work. Or you'd have mobile populations where people came from the country, and then the summertime they would come to the urban area, or vice versa, right? And that was not captured on those tools, so we had a big discussion on how to improve the tools so that they captured these populations so that they didn't go into the numerator and create greater than 100% coverage rates. So this is a question that I think that as we move through, we're going to talk more about the forms and how potentially we can improve forms in order to capture certain populations so that they don't get in the numerator when they shouldn't be. So there's also, as a complement to administrative data, we talked a lot about coverage survey, and I'm not going to go in depth about that because I'm not a statistician. I'm going to let Mamadou talk about that after, I think this afternoon after lunch. And, but I do want to kind of cover a little bit about this and again relate it to equity and special populations. So, of course, your administrative data, again, is to evaluate and improve program and information, your immunization information system, right? You're supposed to use that data. It's supposed to help your programs. And then the coverage surveys, it's to help support that, especially if you have some questions about the quality of the data. You can use a coverage survey to kind of see and compare, and then also to answer specific questions. You can design the coverage surveys that way, which is a good thing. The last point here, increasing interest on assessing coverage disparities has been something that's been more recently introduced. And I think with the coverage surveys, it's an opportunity to do that. So there are many, many different coverage surveys. I think you guys are all familiar with these things, mixed, DHS, and then there's the WHO vaccination cluster coverage cluster survey, which has a new methodology. It's a lot more complex and requires a lot more technical assistance. Has anybody gotten updated yet on the new methodology? Can I, just a little slight show of hands if you've been updated on newer methods? Okay, okay. So, there you go. The new WHO vaccination coverage cluster survey. Down here is, and we can write this link out. If you guys want to go on the WHO website, they actually have the draft there to take a look at it. So the methodology now is more aligned and is a little bit better. It aligns more with what they call the, let's see, household cluster survey methods. And what they want to do is improve the accuracy of the data. I think most of this I'm going to leave to Mamadou because we found out yesterday that we're going to be repeating information. So the main enhancements and what we need to talk about, because we're talking about like numerator, denominator, is looking at probability sampling, weighted analyses. This is where the technical assistance, I think, initially anyway, is going to be important. And the idea is to minimize the bias, improve the overall data quality. So this also I will leave to Mamadou. But the challenges, the thing that I want to bring up about this, and you are going to get a lot more of this in the next session, is that it's still going to be dependent on your populations and what you know about your populations. So you need to have, for this particular methodology, you'll still need to have good maps. You need to have good microplanning, which is why we're here. And otherwise, you won't be able to do good household selection. The other thing that might fall through the cracks as well is if you have a homeless population, because how do you describe a household, right? If you have a population that's homeless. So the other thing that people are using, I think that will also come up, are digital coordinates, GPS coordinates. You see a lot of satellite imagery now where you're looking at settlements and trying to estimate populations that way. But these are also, they're very expensive and therefore can be very limiting. So, those are the big things. Now, and that's just a very brief overview, I think, most of, like I said, what we talked about in the EMRA workshop had to do with the data quality assessments, newer components of the methodology, the new methodology in the coverage survey, and kind of pointed out some situations where you may still be missing equitable populations, your special populations. So when we're talking about data quality and the movement of data, I mean, how effective do you think? Could anybody give me some comments? I just kind of want to hear from people what they think about the effectiveness of the current methods for capturing and reporting your special populations. Yes.
I think what we understood with Kamal's summary of different groups, basically on specialized populations, I didn't hear any good example of any data collection. With the surveys even, that is the only option that we do, is we do sporadic surveys, either API coverage survey in small areas or DHS and mix. There also, other than urban, rural, and wealth quintile, we are not having the information on others. Even the IDPs are not being captured regularly in any surveys. So to me, I think our answer is currently we don't have this information. And if we understand a bit little on the WHO's new coverage methods, whether these specialized groups are included or not, otherwise we will be in the same situation even for another few years.
Yeah. Thank you. And I know Jordan on their forms, they have now a selection whether or not you're from Jordan, from Syria, from Iraq. Am I correct? You guys want to? Yeah. Yeah. So let's ask them.
In fact, within the conflicts of neighboring countries, we face fluctuation of the coverage from our all districts. Because we can't define the denominator exactly. For the numerator, it is we can all children that have received the vaccine, but the denominator is not defined very well at every district. Because we're suffering from refugees not from Syria, from Libya, we have from Yemen, from Iraqi, from all countries that are suffering from conflicts. So as the denominator is not exactly defined, and it depends on the calculation of the coverage in general. Some like our colleagues they are represent region at the border side. They have some high risk areas with low coverage of vaccination in general for all vaccine. But in general, among our Jordanian population, they are aware of vaccines. We have a high coverage for all vaccines among Jordanian, more than 95% for all vaccines. But the distribution of refugees in all territories, as we will share with you, from Amman to Aqaba, we have more than 2 million inside Jordan. They affect our program, especially how to calculate the denominator. And we are thinking about the best methods for calculating the denominator. They have big movements. Sometimes one city, we can calculate the denominator after 1 to 3 months. The denominator will be different. This is the problem now.
Yeah, I think that the denominator issue is going to be a big challenge, and it's something that's not unique to any one country. I mean, you have people moving. I sat with Syria for a little while, and they have populations coming and going, so the numerator works out fine. You can get numbers, but then you don't know how to calculate the coverage rates. So that's something that's it's going to be a challenge pretty much, I think, almost in every country. Yes, sir.
Mainly the problem in Egypt is not during the routine immunization coverage calculation, but with the polio immunization days, because we use the house-to-house strategy and mobbing up in the streets and everywhere. So sometimes, not sometimes, actually, the coverage is always 106 or 105, and because that it is difficult before the campaign itself to identify the denominator. So what they usually use the previous campaign coverage, and then they depend on it because they need the number to prepare for the immunization teams, vaccination teams, the amount of vaccine required and everything. But at the end, they do not have, or we do not have an accurate denomination number. That's why we stuck with this percentage of coverage at the end, which is 105 or 106.
And let me ask, does anybody have, do you have on your forms, like your data collection forms at the health center, do you have specific boxes for visitors or people who are not in the target area? Do you have that? And how is it analyzed? Is it, here, I'll let you, please.
Yeah, in special form for visitors and the others, IDPs or something, yeah.
Okay, so you have a special form then that you fill out for the IDPs or for visitors, people who don't fall into the target population, correct?
The visitors not come in the routine immunization for that health center. They returned back to the community's area. The child belonged to them.
Okay, so, but they can
took
be
the
vaccinated.
vaccine, yeah.
They'll be vaccinated,
and then
okay.
give it a letter to the health center.
Okay, so, yeah.
I think I'll take from Iraq point of view. Every country that I have worked for has got extensive and wealth of information in their recording format and in their reporting format. The problem is I think nobody has helped them and guided them in analyzing, and they have not done. For Iraq case, at a national level, she has got the data of the whole population. And our slogan was, we have no problem in aggregation, we have problem in the segregation. Because when she gets all the district data, she gets the overall rate and the national level is showing good result. But in between, there is 4 governorates here. People have moved from him to her and from her to there. This is where we are finding a problem. But when she calculates the national, there is no problem because all are Iraqi children. So to me, I think this is the first workshop we are having when people are really getting into the bottom of the equity. Otherwise, all the time is the national average, the routine coverage that you talk about. The separate, nobody has helped them, but everybody in their format in Iraq, they have got IDPs, they have got refugees, they have got newcomers are not going, but nobody has ever analyzed. That's my understanding with her.
No, that's a really good point. And we have, Sudan. Sudan has a comment. Yeah, hold on.
Okay, thank you. Also, when we talk about the denominator in the fixed site, just like a hospital, it is not mentioned as one catchment area. They used to serve different areas. So it is so difficult to calculate the denominator for this fixed site when we talk about grassroots planning from the catchment area. So this will be this is also a problem for us. But for the national level, it is okay. The total number of vaccinated children will be there. Okay.
Yeah, I think as it moves up nationally and you're capturing the people regardless of where they move, then it kind of evens itself out and becomes more accurate. But let me ask, this is not up there. This question is not up there. But what kind of things, what type of guidance would you be looking for, like to help with improve your data quality? Especially when it comes to these special populations.
Yeah,
As already mentioned, the fundamental need, the record keeping and reporting. The first and second, how best utilize that one. Even in some case, that is exists, but that one is not, to some extent, properly utilized. Like if I give you the example of, for the SIAs or for the campaigns. So in Jordan, during last 3-4 years, so based on the previous campaign, the data, we categorized that one. We were not able, to go to the nitty-gritty of different nationality, but we categorized them in 3 categories. Even during the microplanning, there were Jordanian, Syrian, and other nationality. And even we benefited from this one, so that is why we use this one during the polio control room regular meetings. We managed to discuss with Ministry of Health, and Ministry of Health, consider that point in right now at the health facility level, because that was one of the problem, and that was our concern because of the numerator and denominator, because that one was not counted like right now. They are talking about 2 million, but in the reality, there is 650,000 plus minus, registered one, and there are unregistered, maybe this equal number, or so the need will be, how they will have, the tracking system, where there will be a defaulter, and where will be, they will reach more than their denominator because of this because in Jordan we have 5 different high-risk group, which they are the contributor of, this data quality. And that is why if we have, the better reporting, record keeping and reporting, then that will help them, to understand. Like now comparing with at the beginning, so we are a little bit relaxed because we know what is going, like already our colleague mentioned, we know where is our problem. Our problem is not with the Jordanian. The biggest problem is with the refugees in the other, high-risk group. But in our data, we don't have, that nitty-gritty in details to really find out which group we have this problem. So that is why we need, the proper record keeping and reporting, or the easy solution is, the mobile data collection, which now we are hopeful, because we experienced this one for the REC project, and we are right now replicating that one for the routine. And we hope we will manage to find more details, and that will help us to really know the real administrative data, and as well as that will help us for the national coverage.
Okay, that was good. I'll come back in just a second. Over here, do we have? No? The question, we can go back, Lebanon, for like what type of assistance or support, guidance would you want look for like these special populations and data quality, data analysis? Yeah? You took a breath, I'm sorry.
Yeah. No, the challenges that we're facing with data specific to Lebanon, Lebanon is a very small country, and there is no separation or large distances between district and another. So, and we have the issue of shopping for services among all primary healthcare centers. So a person who is a displaced person can get a service at one governorate today and go to the next governorate tomorrow, and they are just very close to each other. So the separation at a subnational level, it's a bit difficult for us. It is challenging. Anything else?
Okay, maybe one more. How much? Egypt. Oh, Egypt is commented. Yes, any other? It's what?
I mean, we commented already about the problems that are facing for the quality of data, but because
Is your mic on? Okay.
But because, Egypt is one of the very central countries, so data is coming exactly like what you mentioned, from the peripheral to the central level, where it's accumulated, and then we come out with the figures of coverage, depending also into the registered children at the end. So if you have a discrepancy in one area that it is under coverage and the other one is over coverage, at the end it compensates each other, and you got the accurate figures. But at the end, as I told you, the problem is in the NIDs, in the polio national campaigns. This is the one that really we don't have an accurate figure for the denominator. This is number one. The most important thing, number two, kindly can you open the air condition? It's becoming very hot.
That's immediate environmental control. So Syria, any? Yeah, you want to use the mic?
In Syria, it's very difficult at governorate level and district level to differentiate between people from the same governorate and people displaced. So they are considered as a Syrian people, regardless the original of the families. So, most hosting governorate receiving high numbers of children comparing with other governorates. So this is the case, and for Deir ez-Zor especially, we have a lot of Iraqi refugees, and but unfortunately due to political issues, they are considered as Syrian, and they get their vaccination at the health facilities without any restrictions. So there is no special system or reporting format for IDBs or
okay.
refugees.
Do they get included then in
Yes.
the reporting? Okay.
Yes, yes.
Okay.
So because of that, we have now very high coverage for Deir ez-Zor because they have accepting a lot of Iraqi people.
Okay. Okay.
Thank you. sorry. Actually, in Djibouti, we are conducting the DHS mix survey, and we are at the stage of the elaboration of the modules, and we are trying to now to put those population in, and for further assistance, we are now trying to discuss with the Minister of Health and the National Entity of Statistics, and for further assistance, we'll talk with the regional office if we need it.
Okay, thank you. And I think one more, we'll have you want to give last comment?
Thank you very much. We had a quick discussion in between. I think the Ministry of Health is busy in delivering the vaccination, and they are busy in coverage. It's UNICEF and WHO, we demand on data, and we need more and qualified data. So what our understanding is that at the moment, there is no clear instruction at district level or peripheral level to calculate this specialized population. And in the reporting format, they would be good, like good example is from nutrition. They have got a formula for each column, that how each column, and at a supervisor level, at district level, how you check before you release that your data is consistent and your data makes sense. Only then at national level she can compile. So to me, if the format gives all these specialized population with a formula and how to calculate and revise in the training modules to go through a massive training up to the grassroots level, how to study the data, and that is, I think, best help they could get.
Okay, I think these are all very useful discussions right now. And so I'm just going to kind of summarize a little bit, and then let me know, anybody, because this is, again, informal, if you hear something that was a little bit different, all right? Because what I'm hearing a lot of is that we do have, every country really has, especially with these special populations, a challenge with the denominator and trying to get a good denominator, right? It always works out a lot better if you can consider the denominator from a national level than from a district level, especially when they're moving. But as far as assistance goes and asking about what type of guidance you need, it's more like guidance on how to collect the data, right? And then how to analyze and use the data.